Now, security.
Don't you have a better banner? Don't let anyone in.
I just wanted to see all these people.
You see, they've already joined.
No, they are really keen for these things.
No, some they just join and they get on with their day
Oh,
so that they get the points.
is it? So then they don't join to actually.
Well, some if it's an interesting topic, some they do.
That doctor, when we were not joining, the topic was interesting. She's a great speaker. She's easy to work with.
Which one?
Dr. Pooja.
Um,
Dr. Pooja.
oh wow.
It's the
Baby
very
roll.
raw.
Mixed berry. So this one having to join. I'm sitting right here. And then you went out.
You said you're gonna send me the message, Mos.
Well, I'll type it off and take it. But it's more like.
Please type it out.
Hmm?
Please type it out.
Yeah, I'll write it there for you.
Mhm.
When's your earring?
Welcome to clinics webinars.
Please post your questions on the chat box. They will be attended to. Oh no, but she's gonna say that you're gonna attend to the questions at the end of the session.
Hi, Prof.
Hi, how are you?
We good. What did I do? Hi, Prof. How are you?
I'm good. How are you?
Are we good? We good. Thank you once again for agreeing to host.
It's a very big pleasure.
We're just gonna wait for Dr. Kinoshi, but we can assist you with your slides in the meantime.
Oh, I should be able to share.
Okay.
Wow. Can you see it?
Yes.
Yeah,
I can
definitely.
see it.
There we go. So that's easy enough.
Yeah, no, it is.
Okay, then we don't have to worry too much.
Yes.
Okay. We're starting at 6:30.
At
I mean,
6.
6 o'clock, hey?
6 o'clock.
Okay.
Yeah, so this 30 minutes is just to set up and stuff like that. But I
Okay.
see everything is good from your side. So we'll see you at 5 to 6.
Perfect. I'll see you then.
Thanks, Doc.
Thanks, hey, bye.
Bye.
Good afternoon.
Hi, guys.
Afternoon.
Good afternoon, everyone.
Dr. Maurice is struggling. Dr. Kinoshi.
Dr. Kinoshi, are you good?
Try to call him Prof.
Maybe if you make him aware that we spoke to Prof and we checked everything.
How are you? Good evening. I'm at the office there with the marketing team. I'm with Verwey and Sam. Just wanted to see if the actual system works, and I see you are admitted now. And they spoke to the doctor. The presentation is
The professor.
uploaded.
Everything
And
works.
yes. Okay. Yes, I was here when they admitted.
Hello.
We can
Hi,
hear
Dr.
you.
Kinoshi.
Okay, let me unmute. Can you hear me?
Who logged out?
Prof.
Yeah, I see now. We shouldn't, the host should not log out. Then they have a problem logging in again. We shouldn't have let them log out. She must stay logged in, and we should test both the audio and the video and the slides on the screen.
So who's gonna call him now?
Who was talking to him from your side? Maybe let me find out. Is it
It
Dr.
was
Like,
you and Sam.
is it Aviwe and Sam?
Yes, Doc.
Yeah, because we shouldn't all be talking to him at the same time. Otherwise, they get thank you. They get messed up. So I think we shouldn't have let him to this thing. So if you want me to call him, I'll call him and I'll ask him to log in and stay logged in.
Please do.
All right, thank you.
Okay.
Okay, I'll just testing my camera as well. Is it?
Oh no.
Is it visible?
Yes,
we
you
can
are
see you,
visible,
Doc.
Doc.
Okay, I'll adjust this further if there's a need to do that. Okay, I'll put it. Yeah, because when I talk to people, I should put it on, and then I put it up only during the presentation. I put it off, and then during a question time, then I put it on again. Okay, great. If my audio and video are fine, then I'm going to switch off this, and I'm giving him a call now.
Okay.
Thank you.
You don't use a mouse.
Sam, happy birthday.
Oh, is it Sam's birthday today?
Yeah, but
Thank you, Dr. Nko.
Happy birthday, happy birthday.
birthday
He
to
didn't tell us.
birthday to
We make him.
It's a webinar.
We make him.
dear Sam.
Thank
Happy
you, Dr. Morris.
Birthday to you.
Beep, beep.
Hooray!
Now we make Sam work on his birthday till late like this. We apologize. We owe you a chocolate.
We'll buy him a cake.
Please, that will do. I think we need to find him.
He's not baking. Akira is gonna call him.
Yeah, I'm calling him now. Let me just.
I will leave at 6.
No, I'm leaving at 6.
No, you're not.
Why not?
You're staying.
For till after 7.
Mm-hmm.
Why? No, like what?
Yeah, Prof is logging in. I hope you've admitted him on your side.
Yes, we have.
All right. I just want to see.
Dr.
There we
Kinoshi,
go.
is that you with the Oh, it's Tolagele.
Okay, I'm back.
Tolakele, I've just got a message from her that she just arrived and she'll log in soon. I haven't even had time to answer a message, but she just sent me a message that she just got home now.
Am I here?
No?
Good afternoon. Is it Tolakele on the line? Okay.
Hi team, hi colleagues. I think I'm here,
Okay,
but
that's
I
great.
can't see my
Thanks.
name. Okay.
Thank you. So, where is Prof?
I'm here. Can you hear me?
Oh yes, now we can hear you clearly. Can you hear me clearly, Prof?
Yeah, I can hear you clearly.
Yeah, so what we'll do, let me just unmute my camera.
And can you see my presentation as well?
I can see your presentation very well.
Okay,
Yes.
good.
My camera is now blocked. Tolagele, whoever is on their side, because I put it on my side. We'll also
It's Aviwe, Doc. It's Aviwe.
Oh, Verwey. Oh, she's controlling. Okay, Verwey, earlier on I could open my camera, now I can't.
No, it's on. You
It's
can
on,
see you.
Doc.
Oh, now it's off. Now it's
Now
on.
it's on.
Yeah.
Okay, I can't see myself. Okay, on the screen, but that doesn't matter. As long as I can see Prof and Prof can see me, and that's how Prof will look to all the audience. And if I need to do anything, you let me know on my side. But if
you want me to keep my camera on while I'm presenting?
Well, during introduction, yes. I'll introduce you as the speaker of the day, and then thereafter, when you present, it's up to you. You can switch it off.
Okay.
But at question time, it's better if we then have the two of us will have our cameras on when we do
Okay,
the
great.
question and answers. And is it Sam who will be assisting us with maybe the questions on the chat? Because I'll also, some of the questions, they'll put it on the chat as well.
Okay.
And
how long do I have to talk again?
Excuse me?
How long do I have to talk again?
Your slides are fine. I think they're 43. It's about average.
Okay.
But then most chats talks are between 30 and 45 minutes. But
okay,
if it's
now I'll get there.
If it's slightly longer, it's fine. It's just that when we get past 7:30 p.m., some people start logging off. Usually
I won't get there.
Yeah, we want to be done with the presentation by about 45 minutes, and then so that we give them another 30 to 45 minutes of question time.
Okay, great.
That's right.
Okay.
And at the end, I'll have one of the professors doing a vote of thanks at the end. Okay. Thanks. Yeah, I think everything is fine. I think we can log in at about, it's already at 5:02, Prof, if you want to. Okay.
Prof, please don't log out. Just mute yourself.
I will. I won't log out again. I won't log out again.
Yeah,
Okay.
I'm just muting myself as well, both camera and.
Thank you, Dr. Kinoshi.
Whilst I'm here, I did ask about the clinic's video clips, but Tolakele did not remember them. We used to start with, at times, not all the time, but some Thursdays we would start with a video clip promoting the day hospital or Speaks, Dr. SK, and so on, because there are some video clips, marketing clips that we used to start with. They last about 3-4 minutes. At 6 o'clock as people are being admitted, and then before the host starts opening the session. So, but Tolakele says, because she started in September, October, you don't have experience of them. Do you have experience of those video clips? I don't say you must get it now. It might be too late, but in future.
And no, Doc, I've never played any video clips.
Oh, okay.
But we'd said we're gonna reach out to Kamo, and
Exactly.
yeah, maybe you can also provide those videos and maybe show
Yeah,
us.
they're so beautiful. You'll want to show them more, more and
Yeah,
more because they promote clinics, facilities. They've got some of the executive managers. One has got Dr. Matseke actually saying something in the clip. And the one that says Kolo, the one says so and so and so and so. So there are quite a number of clips. I can't remember how many. And but it was during Gamu and I think who else
Anza.
was there? Sorry.
Anza.
Yes, Anza, Gamu, and
Togo.
yeah. Well, Togo never really did the webinars. She was like in the managing in the background, but there was, is it Pumulo? Is it
Puseledzo.
Puseletso? Yeah, Puseletso, yeah. Okay, no, that's fine. I think we're good. I'm going to mute until just 3 minutes before.
Okay, Doc.
Okay, so you'll start admitting people at what? At
2
when do you
minutes.
start? At 5 minutes before. Okay, sure.
5 minutes before.
Thanks. Okay, bye.
Dr. Kinoshi.
Yes. Okay, I'm muting myself.
Dr. Kinoshi? Dr. Kinoshi?
He's not answering his phone.
Okay.
Prof? Let's get Prof back, Doc, and then I'll admit people. We've got 112 people.
All right. Is he back now?
Yes.
Okay. Okay.
So are we ready?
I am. It's you can admit people, but it's 2 minutes too. Mine says 17:57, but you can admit them. But I won't say anything until it's time.
Okay.
Until 6 o'clock, right? Okay.
Yes. Okay.
Okay, can I start everywhere? Is it Avia or Sam?
It's a view, Doc. Yes, you may start.
Okay, all right. We've got 135. Good evening, everyone. Welcome to yet another Clinics Health Group.
We can talk.
Welcome to yet another Clinics Health Group webinar. Clinics has been running these webinars since COVID. I think COVID at least has left one positive legacy. I think that's virtual meetings all over. So I think the whole globally, the whole world is gaining from that aspect of the pandemic, even though it left so much destruction. But welcome. This is yet another Thursday one. We try to run these webinars every Thursday, except of course during when there's a public holiday intervening, or whenever there's any other matter, especially over festive season or something. But otherwise, we try to run them as much as we do on a regular basis. The webinars, the presenters, although it's run by Clinics Health Group with the support of the Clinics Board and the Exco of Clinics, the speakers are sourced from academia, academic our clinicians. It's sought from private clinicians. It's also sought from general practitioners. We invite speakers from yourselves, and speakers can also themselves approach us to speak on any topic that is of interest in the healthcare field. We also encourage the audience to also suggest to us any particular topics that they would like us to source speakers on. I think that's also great. You can reach us on the numbers that are on our website, but we also, with partnership of SAMA and the HPCSA, Health Professions Council, we provide CPD points to both speakers and to the audience, whoever logs in and has registered and logged in to any of our webinars. I think we are thankful to our marketing team and our technical who do the technical side of the webinars, and we continue to be strong because of you who managed to log in. Our speaker this evening is none other than Professor Charl Verwey. Professor Verwey is the head of the pediatric pulmonology unit at Chrisani Bara Academic Hospital, Vets Medical School. He has been with the institution for some years. He's a well-known researcher, and he not only did he get his he got his MBHP from University of Pretoria, Tekis. He's got FCPs. He's got a certificate in pediatric pulmonology offered by the Colleges of Medicine of South Africa. He has a MMed degree, postgraduate degree from Wits, but he also has a PhD from the University of Witwatersrand. His favorite topic is respiratory syncytial virus bronchiolitis, which he's going to talk about today. And I think without wasting more of your time, I think over to you, Prof. I think you can put your camera on so that they can see you initially. I think they've got your presentation is on the screen. You can go ahead, Prof.
Thank you. I hope my camera, I think my camera is on at the moment, so I don't know if you can see me. But I'm going to put it off now so that you guys don't have to look at my face the whole time. So thank you very much, Dr. Kanoshi, for those introductions. It's very nicely spoken. Thank you very much. So as been mentioned, one of my favorite topics is RSV and bronchiolitis. And we've all noticed all the rain recently in Johannesburg and Gauteng. And as soon as this rain is over for the season, the RSV season is probably going to start quite soon. So it's a good time that we should be discussing this topic on RSV. I'm going to give a broad overview first, cover the basics first of RSV, and then go to the epidemiology and see why, explain to you why it is such a big problem, and then then start exploring the few management options that we do have, and then also going to some new developments which are quite exciting in RSV. It's one of the last frontiers in LRTIs, but I'll speak more about that later. I do have a few conflicts of interest. I do converse with pharma companies every now and then, and I have received money from them as well, but hopefully that won't interfere too much with this topic today. I have to be honest, I'm a complete pediatric pulmonologist, and that's what I like. I think the lungs are beautiful, but that's not that important. What I like, what I want to express with this slide is that the lungs they are beautiful, but they're also extremely delicate, and every single breath we take can cause damage to the lungs or not. But a lot of things can cause damage to the lungs, and if you look at the lungs that I've shown you, they're extremely delicate organs, and we have to have great defensive mechanisms in them to protect them. Or if we can't have great defensive mechanisms in the lungs themselves, we have to protect them from the exterior by things like vaccinations and management and treatment, which we don't always have. But what I want to impress here is the lungs can be easily damaged, and there's a lot of things that can damage them. And bronchiolitis is probably one of the most important infections that can cause damage to the lungs of children. So the definition of bronchiolitis, and we often use RSV and bronchiolitis almost interchangeably. It's not 100% the same thing, but it's very similar. But the definition of bronchiolitis is an acute viral infection of the lower respiratory tract. And when we talk of the lower respiratory tract, it's usually an infection of the airways, an acute viral infection of the smaller airways. You can see on that chart, on that picture on the right there, where the bronchioles are. And this is where RSV attacks, and this is where RSV causes its damage. And by causing damage here, it causes the typical symptoms that we see. If you take it a bit smaller and you look at this microscopy picture, you can see the respiratory bronchioles and the terminal bronchioles, and those are typically the airways that are affected by RSV. And when they do get infected by RSV, you get necrosis, inflammation, edema, and mucus secretion in that area. And you get a lot of plugging of that area and desquamation of the cells. So they block up the airways and cause obstruction of the small airways. And you can see the pictures in the bottom there showing a patent bronchiole and then a RSV bronchiole that's completely blocked up. And this obviously leads to obstructive lung disease. And what I'd like to highlight here as well, just in the beginning, because we're going to speak about management a bit later, is that if you look at this, apart from the inflammatory part, we'd think you should notice that none of these problems, none of these pathological mechanisms are actually treated by steroid therapy. Yes, there's inflammation, which we can argue is treated by steroids, but this is neutrophilic inflammation that's caused by RSV. So very little response to steroid treatment in your typical RSV bronchiolitis. And that's because it's not eosinophilic driven, it's neutrophilic driven. This is always nice to put a bit of physiology in. We've done the anatomy now and then put a bit of physiology in. And this is why the concept of bronchiolitis is so much more severe in small children, and it's all got to do with the size of the airways. You can look at Poiseuille's law there, which shows you that flow is directly related to the size of the radius of the airways, and the smaller the airways get, the more obstruction and the decreased flow you'll get. And obviously, when we're talking about small children, they have very small airways, and when you do have a decrease in the radius of the airway, you have a very, very large decrease in airflow. And that's why bronchiolitis is typically a disease of the first 2 years of life, and especially in children like premature babies or children with bronchopulmonary dysplasia, because it's all a disease of small airways, and the size of the airway is extremely relevant in bronchiolitis. So all of these pathophysiological mechanisms I've mentioned now, the obstruction of the airway and the decrease of flow, leads to the clinical picture that we see so often during what we call the RSV season. And I'll explain that, I'll define that a bit better shortly. But it leads to the clinical results of hyperinflation and wheezing. Hyperinflation, it sounds silly, but there's too much air in the lungs because the children can breathe in the lungs, but as they breathe out, the airways collapse. And this causes air trapping and hyperinflation, and all the symptoms of the signs of the increased AP diameter of the chest. The wheezing is all due to the obstruction of the airways and the hyperinflation. And you can see that X-ray there as well, the typically hyperinflated X-ray of a child with RSV bronchiolitis. You can see there's too many anterior ribs. There's 1, 2, 3, 4, 5, 6, 7, 8 full anterior ribs above the diaphragm on the right. And there's also air. You can see the heart is almost lifted up because of the air there. And if we go to these x-rays here as well, we can see all these ones are the typical signs of bronchiolitis. So hyperinflation with flat diaphragm, narrow mediastinum, increased volume of the lungs. But increased volume is not necessarily a good thing because there's too much air in the lungs and they can't breathe out. That's the problem with bronchiolitis. You've got a problem with exhalation of air. So you've got a problem with expiration, basically, and you've got hyperinflation and air trapping. And that's what makes it so difficult often to ventilate these babies, because they already have too much air in their lungs more than hypoxic problems. It's a ventilation problem, not a hypoxic or oxidation problem. But why? I mean, we know that RSV doesn't have a very high mortality rate. So why is there so much emphasis put on RSV at the moment? Well, it's quite simple, and numbers don't always tell the exact story, but I'll give you some numbers. If you look at the global under 5 mortality rate, it's decreased quite a lot over the last 2 decades, and we're doing very well. From the year 2000 to the year 2019 in South Africa, it's decreased from 78.1 deaths per 1,000 live births to 34.5, and the latest figures, if I'm not incorrect, is about 27, 28 deaths per 1,000 live births. So we're doing very well there. And the reasons we're doing well with the care of children is that there's improved home care and management of newborns. There's the IMCI program that's been very successful in dealing with in recognizing severe and early signs of disease in children. There's improved childhood nutrition, and there's also, believe it or not, we have a very good expanded program of immunization, so a very good vaccination program in state and in private as well. And that's managed to decrease the under 5 mortality rate by quite a bit. Nevertheless, there's still about 5.2 million deaths in children less than 5 years of age every year in the world. And the leading cause of these deaths is lower respiratory tract infection, accounting for about 12.1% of children globally. And you can see in South Africa, the data is between 9.9 and 17% of children in South Africa who do demise from lower respiratory tract infection. And most of us know this, that irrespective of whether you have a pneumonia or you have bronchiolitis, the leading cause of lower respiratory tract infection, which is the big term that encompasses both of those conditions, are viruses. So viruses are by far the most common cause of lower respiratory tract infection in the world. And there's very good data on that. You see from that paper in the NEJM and from the study done in South Africa. Well, South Africa was one of the sites. The PURGE study showed that viruses are by far the most common cause of LRTI in cases with an abnormal chest X-ray. As the severity grows of the LRTI and the severity of the X-ray abnormalities, it's more likely to be bacterial. But in general, 80% of the children with lower respiratory tract infection in South Africa is due to viruses. And we also know, and this data is also very well known, whether it's South African data or global data, is that the most common cause of lower respiratory tract infection is viruses, and the most common virus is RSV. They get many other viruses as well. At the moment, there's a lot of rhinovirus going around and a bit of adenovirus going around in our surveillance when we check children for LRTIs. And RSV, we haven't had a case at my hospital, at Baragwanath Hospital, yet in the last few weeks, but we're waiting for the anticipation. So it's bound to come, but at the moment it's mostly rhinovirus. And then South Africa is a bit of a year in Joburg, it's a bit of a silly season because first there's respiratory syncytial virus, and as soon as that finishes, we'll go into the influenza season. So a lot of problems. We do know, however, that there is a vaccine for influenza virus, and that is very effective. We don't, however, kind of have a vaccine yet for RSV. So how big is the problem of RSV now? I'm going to stick to RSV now and use it the same way as I use bronchiolitis, use it interchangeably. Well, the first systematic review looking at this was done in 2010, and this was expanded on again in 2017. And the numbers are vast. And even though the mortality rate isn't seen as that high, the numbers are massive. And I'll just go to the next slide and show you here. This is from the 2019 paper by Shi in the New England Journal of Medicine. There's approximately 33 million cases, severe cases of RSV every year. And with severe, we usually mean a child that has at least tachypnea. About 3.6 million hospital admissions per annum for RSV and about 101,000 deaths. So maybe not as deadly as something like tuberculosis or strep pneumonia, but an extremely big problem because of the amount of hospitalizations and the amount of severe cases that are seen. And let's be honest, 101,000 deaths from a single disease is still massive. We also know that the majority of the children that are affected by RSV and the majority of these severe cases, hospitalizations and deaths occur during the first 6 months of life, with nearly half of all of the cases in the first 6 months of life. And we also know that about 97% of all these cases of the deaths are in low and middle income countries. That's a blank slide for some other reason, but I want to skip to this slide here. And what we also know, what we're learning quite a lot about now is, especially in low and middle income countries that already counts for 97% of the mortality rate, is that there's probably a very large underreporting of the deaths, especially in the community, and probably only about 10 to 25% of deaths in the community actually have a cause when you deal with LRTI. So the majority of the deaths probably occur in the community, and so we've probably completely underrepresented the mortality rate in low and middle income countries when it comes to RSV. Some numbers from South Africa, and you can see here that once again, this study was done in looking at deaths in South African children between 2011 and 2016. And it shows you again that the smallest group, the less than 1 year, are the most affected group. And also the less than one month is the most severely affected age. And we had approximately 652 deaths in children in those age groups, and most of them being in the first 2 months of life. And this is data from South Africa. What we can also see is that in studies done is that apart from the morbidity and the mortality of the acute infection, there's a lot of problems, long-term respiratory sequelae of RSV. And this is a systematic review that was done a few years ago, which showed all the studies at that stage looking at lung disease or lung sequelae after RSV infection during infancy. And the longest one there was up to follow-up of up to 30 years, where still at 30 years of age, in children who had RSV during infancy still showed some obstructive airways disease. It's not 100% determined yet what the long-term sequelae are, but the general consensus is that children who have a confirmed RSV LRTI during the first 3 years of life often have abnormal PFTs, and this can stretch up to 30 years, and it's usually obstructive lung disease, so something that we call a post-infectious bronchiolitis obliterans often, and we can't do much about that treatment-wise. So apart from the acute morbidity and mortality, there's long-term sequelae as well. What are the long-term sequelae? But as I mentioned quickly already, you can be very lucky and you can be a healthy child that develops RSV and has absolutely no sequelae afterwards, or you can pass away from RSV, as we've shown 101,000 children a year do. But you can be somewhere stuck on the spectrum in between as well. We know that children with bronchiolitis during the first year of life are 2 to 3 times more likely to be readmitted for any lower respiratory tract infection during the next year of life and the next 2 years of life. We also know that they're much more likely to wheeze and to cough recurrently during the next 2 years of life as well. So those are problems that come after RSV infection. And we also know that some of them can get what we develop post-infectious bronchiolitis obliterans with long-term sequelae as well. What isn't so sure yet is RSV's influence on asthma. And does RSV cause asthma or influence asthma? We're not really sure about that yet, but those studies are ongoing in that. I've spoken quickly here now about long-term sequelae of RSV, and I just want us to be all aware of these few pictures over here from different studies. And basically what it shows is that the lungs are delicate, delicate organs, and you can influence the development of the lung from the embryonic stage of development. Definitely during the birth stage, so preterm birth is obviously a huge problem, and lifelong throughout, well, yeah, throughout life as well. The lungs can be influenced the way they develop. And when we're born, we are basically born with a predetermined lung function trajectory throughout life. And any insult to this can actually decrease our lung function trajectory. And it's very difficult sometimes to get that lung function back. Early infancy lung infections are directly related with the development of COPD in later life. And so all of these things, if you look at the major numbers we have patients with COPD, all of these things can be influenced by looking after the lungs during early development and just after birth. And RSV is one of those diseases that can cause long-term problems in the lungs. And we know studies from Cape Town have showed that just one infection with RSV will increase your respiratory rate and decrease compliance. And if you have more than one infection with admission, these compound each other. So early life infections can affect your lung function and your lung health throughout life. And this is important and why we're so hard in chasing cures or preventative measures for RSV. Financially, we had a cancelled budget speech, and maybe that's because they were trying to make space for RSV vaccination and prophylaxis, but I seriously doubt it. But just this is a study done by Jocelyn Moyes and the group from the NICD looking at the economic burden of RSV in South Africa in children under the age of 5 from 2011 to 2016. And you can look at these numbers. This is in US dollars. It was reported in US dollars. And just in South Africa, RSV has been shown or been reported to cause about 137 million US dollars damage or cost to the healthcare system in children under 5 years. I mean, that's a huge number. And 76% of this is covered by the healthcare system and 6% out of pocket to the parents. So in a country that doesn't have many resources, this is a huge burden. And they also see that if you look at full-term births and preterm births, that if you're born premature and you have a RSV associated hospitalization, your general cost is about 40,000 US dollars per preterm infant of under 29 weeks and about $9,000 for full-term infants. These are huge numbers, and if we can get a good vaccination program in place covering RSV, whether it's maternal vaccination, I'm going to talk about that in shortly, or if we can get preventative measures in place, like the new monoclonal antibodies, even though the initial cost seems huge, the long-term cost benefits is very tangible. Okay, so back to basics again. I don't have to talk too much about this, but we know there's two types of RSV. There's RSV-A and RSV-B, and they're very similar. It was always thought that RSV-A was more virulent than RSV-B, but that's probably not true. But we're not 100% sure yet. We generally have smaller numbers of admissions in the years where we have RSV-B than compared to the RSV-A one. So it's difficult to say what the relevance of that is, but there are two groups and they do not alternate yearly, but they do alternate. You'll have a definite subgroup per year. And the next year will either be the same subgroup or there'll be a definite switch where the majority is one. There's not usually too much sharing of the subtypes. The biggest breakthrough that came, let me just start over again, not over, but just out of interest that RSV was first called chimpanzee coryza agent in 1955, and only in 1956 was it called the human respiratory syncytial virus. And one of the big breakthroughs came in, not so long ago. It was basically in 2011 where it was shown. I mean, we know that RSV's got a few antigens on the cell membrane. There's the G protein and the F protein, which are the important ones. And only in 2011 was it shown the F protein that we're showing here now actually transforms once it fuses to the membrane. So there's a pre-fusion state and a post-fusion state. And this made the advent of developing vaccines that can target specific regions a bit more feasible. There's 6 regions on the RSV virus from 0 to number 5. And we know palivizumab binds to antigen site 2 is shown there. And some of the newer ones bind to the 0 or the O antigen, the O antigen. And these are important because when this transformation was shown, the pre-post fusion transformation was shown, we could direct we can direct the treatment to the epitopes that are most available pre-fusion before it actually becomes a post-fusion type. So it's very important there. So RSV is transmitted via, I'm just going to go back to basics now and just go over it again. RSV is transmitted via droplet spread. So it can be from surfaces and it can be from the air as well. And it infects the ciliated respiratory epithelium, and that causes, as we mentioned previously, cell necrosis, apoptosis, mucus hypersecretion, and the release of many cytokine chemokines. And this typically forms the features of the small airway obstruction and hyperinflation that we see. It's quite nice with RSV and with bronchiolitis because we know exactly when it's coming. And as I've mentioned earlier on, it's coming in the next 2 to 3 weeks, probably. After the rainy season here in Johannesburg, it would be the start of the RSV season. And it's been pretty regular throughout the last decade or so. The only difference was there was that thing called COVID a few years ago. We seem to forget about it, but you can see on the graphs on the right-hand side that there's a definite lull in RSV transmission, and that was due to COVID and due to the isolation of the patients during COVID. We don't want to do that again, but it shows that RSV can be prevented if we have strict isolation protocols. But we all knew what psychiatric problems came from the strict isolations because we won't go that way again. And after the isolation was lifted and RSV came back, it came back with a vengeance, and we had a very big season afterwards. So the epidemiology of RSV, approximately 90% of all children will be infected with RSV during the first 2 years of life. But in the majority of these children, it causes a mild illness, basically a cold, upper airway, blocked nose, maybe a bit of fever, and maybe a bit of a raspy cough, but that's it, and then it goes away. It's important to realize as well that the majority of children with RSV that have RSV hospitalizations are healthy full-term infants at about 30 per thousand births per year. And that's basically for the reason that there are more healthy full-term infants than there are premature babies or babies with bronchopulmonary dysplasia. So the most admissions will be in your healthy full-term infants. And that's my second born when he was admitted for his RSV infection, and he was discharged when he was about 18 months of age. That's the same guy. He's now fine, just for the record. Physically, medically, maybe not psychiatrically. But also, there are a few risk factors for developing severe RSV disease. So for admissions and for mortality and for requiring invasive ventilation, so more severe disease. And those are the three main ones are over here: bronchopulmonary dysplasia. And you can see on the previous slide, I said that for term babies, there's about 30 per thousand live births admissions per year. Here we're talking about in bronchopulmonary dysplasia, about 380 per thousand live births. So more than a third of children born with bronchopulmonary dysplasia will have severe RSV during their first year of life. Congenital heart disease comes in second at 92 per thousand live births, and prematurity comes in third. So there's a difference between prematurity and bronchopulmonary dysplasia, even though they often go hand in hand. But prematurity comes third at 66 per thousand live births. So if you have a child with any of these conditions, and they're born within 6 months of the RSV season, you can always predict that there's going to be a bit of trouble on the horizon. There's also a few host and environmental factors that can cause you to increase your chance of severe disease. One is the male gender, because males in general during the first year or two of life have slightly smaller airways. Age as well. If you're born within 6 months of the RSV season, you're more likely to have severe disease, as well as if you have malnutrition as well. You can also have more severe disease. And breastfeeding, as in everything in medicine and pediatrics, breastfeeding is protective and should be actively encouraged. There's also a lot of data that shows if you come from a low socioeconomic status, if you've got overcrowding in the household, if you attend creche or you have siblings who attend creche or a school, and if there's exposure to indoor tobacco smoke, there's a larger chance that you will have severe disease as well. So in South Africa, where we have a large part of the population with low socioeconomic status and household overcrowding, this obviously will become a problem. And indoor tobacco smoke should always be discouraged. Okay, this brings me to the more interesting part of the talk, and I think what most people have been waiting for is how do we manage or treat RSV infection? We know there are a few approaches. We know that we can do preventative measures, and these can basically be divided into isolation of patients, a vaccination of patients, and administering of monoclonal antibodies. And we can also provide supportive treatment options or specific treatment options. So let's go through them quickly one by one. As I mentioned previously, we've got a very specific season, and we can see the numbers are relatively similar over the years. But there was this complete break when we had COVID between 2020 and 2021. You can see there was basically no RSV season. So if we want to do strict isolation, it would probably work, but it's obviously not feasible because we all know what happened in those times, and it's not feasible for children to be isolated. Doesn't mean we can't stop transmission by keeping children home if they're sick, or developing good cough hygiene and wearing masks when people are sick, but it's very difficult to stop those ones. So that's not really an option apart from in hospital to wash surfaces and to create isolation spaces within hospitals. It's very difficult to do. So other management options we have, and I'm going to flip this around. Usually we'd like to prevent before we treat, but with RSV, it's easier to talk about treatment first before we talk about prevention. And this is because for the treatment modalities and preventative modalities that are available. So multiple, we all know, and this is, I'm sure there's going to be one or two questions about this afterwards. We all know that multiple modalities have been and are used for the treatment of RSV infection. We also know there's at the moment still no curative treatment. And we also know that the main treatment should be only supportive. And these are some of the treatments that the top two are the good ones. Supportive treatment, the bottom 5 are not that great. So we need to give supportive treatment. Oxygen is the mainstay of treatment to children with RSV. And this could be based on their requirements. So whether they require nasal prong oxygen, whether they require high flow oxygen, or whether they require invasive ventilation, oxygen is the only proven treatment for RSV. And there's been quite a few studies done on the supply of high flow nasal cannula oxygen to children. And this is what we use mostly in the hospital for our bronchiolitis season, is high flow oxygen. And there have been quite a few studies showing that these are effective, especially if used earlier on. Nutritional support as well. Children can't support themselves, so this needs to be done. And then obviously, then we get to the ones where everybody wants to know about. And that's the supply of hypertonic saline, the supply of beta-2 agonists, the treatment with adrenaline, the treatment with Montelukast, and the treatment with corticosteroids, whether it's inhaled, whether it's oral, or whether it's IV. And all of these can be... Sorry, I think I've just lost my screen there. Hold on for 1 second. Can you let me start sharing that again? I've just pushed the wrong button, I think.
Yeah, but we can hear you quite clearly, Prof. I think it's just the screen.
That should be good. Is that good again?
It's back. It is back on, Prof. You can go ahead.
Thank you. So the hypertonic saline nebs, beta-2 agonist, adrenaline nebulizations, Montelukast in Montelukast and corticosteroids in any form. I'm just gonna do this quickly. Where's that thing now? Okay. Hold on 1 sec. There's always some type of a system malfunction. There we go. They are not recommended, and it's not me that's saying that. It's not me. It's not, it's not my personal opinion. There's been 32 Cochrane reviews, and we know that if it comes to data assimilation, Cochrane reviews is way up there with the top because they're usually systematic reviews and meta-analyses. There's been 32 Cochrane reviews that have been done, and every single one of them shows low to very low evidence of efficacy of any of those treatments that I've crossed out there. There's been multiple guidelines as well, and the table on the bottom right there is the previous South African guidelines, and you can see all of them would say that therapy is not routinely indicated is all of those that I've crossed out. And the only thing that's really been shown to work over the study after study is oxygen to the level that they need and nutritional support. Another question we often get is what about antibiotics? Do we give antibiotics for severe ones? And you'll see the South African guidelines probably will show that in a child with severe LRTI, antibiotics are probably justified. And with severe, we mean admission for high flow or ventilation is probably justified because there is some co-infection with bacterial organisms, but not in your routine children with bronchiolitis. So if you wanted a golden bullet here for the treatment of bronchiolitis, I'm going to disappoint you, and I apologize for that. But supportive management with oxygen and nutritional support, and I'm repeating myself, I know that, but that's your treatment of choice and the only proven treatment that we should be giving. We often get children, not children, sorry, they are my children, but we often get registrars in the hospitals and they'd go, but yeah, what if it is asthma? What if it is something like that? Then we'd say, if you have to do it that way, you can try a trial of hypertonic saline or a trial of a beta-2 agonist nebulization. And so you can do a bronchodilate response or a hypertonic nebulization response. So give one dose, count the respiratory rate before the time, look at the saturations before the time, look at the work of breathing before the time. Give the medication. If there is no response after 15 minutes, scratch it out from your chart and forget about it. It hasn't worked. Because with asthma and the ones that have bronchodilate reversibility, it should work within 15 minutes. And you're going to find the majority of these children will not respond. They will, however, respond to the oxygen. So treatment basically is supportive treatment with oxygen. There's been, over the years, there have been a few drugs that have been tried. There's ribavirin that's been used, which is a broad spectrum antiviral. Not recommended as well. It's complicated by the cost, the complicated delivery, but however, you do get oral forms of the medication now, and it's got quite a decent side effect profile. In the latest review, Cochrane or systematic review that's been done, it has been shown that ribavirin is probably effective, but only in the subgroup of patients that have hematological malignancies. So in those ones, it is recommended because it significantly decreased the mortality, but it hasn't been shown in many of the other groups to actually have any benefit. There's quite a few drugs. I'm not going to go through all of them because none of them are really in production phase or have gone past phase 3 yet, but there's quite a few drugs that are in the pipeline. And let's see, hopefully in the next 5 or 10 years, we might have medications for that. But hopefully in 5 or 10 years, we will actually not have RSV yet because we'll be able to prevent it. This is a nice slide there. This is from the snapshot from PATH. They give this out online, and it just shows you how all the different vaccines and immunoprophylaxis that is available for RSV over the years and in what phase of development they are. And the last few years have been great for RSV because we've come to a stage where we actually have vaccines now for RSV, and we've got the one there we've got 2 for RSV in the elderly, and we've got 1 for maternal vaccination as well. So these are very important to know as well, because we now have some treatment that we can use for children, not for children, but to try to prevent RSV. Another thing as well is that there's also been a new treatment of nirsevimab that's come out in the last few years, but I'll speak more about that in a second. Okay, so the problem with a lot of the vaccines for RSV is that it started off if I remember correctly, it was 1966. Let me just check. I think it was 1966. But anyway, where the first vaccine was administered. What does it say? It doesn't give us a 1963. Long ago. The first one was given, and it was a saline and formalin deactivated RSV vaccine. And the problem with this was that there was much more RSV infection and morbidity and mortality in the year after the vaccine in the controls than in the cases. And this was due to a hyperimmune response that people developed. This was in 68, sorry, it says it there. And after that, there was a big problem with developing vaccines for RSV because everybody was a bit scared. So over the years, there's been a bit of a paucity of research that's been done on RSV because of this initial problems. Luckily, things have changed over the last few years. And if you look at that path chart as well, there's quite a few available options are in the pipeline now, and quite a few that's actually coming to fruition. Most of the ones that are working or that have been gone the furthest is the particle or subunit based vaccines. And as I've mentioned previously, we now have 2 vaccines for the elderly, and we've got a maternal vaccine that's all FDA approved and European approved in Europe, and the maternal vaccine is approved in South Africa as well now, but it's not really available yet. But it wasn't that simple. It wasn't just that they've done this. It took many years and many millions and millions of dollars. And for the first phase 3 trial of the RSVF nanoparticle vaccine did not meet the efficacy targets, and that got shelved. And then the further 2 after that, the maternal vaccines also got stopped in enrollment because it wasn't going to be efficacious. But then a few years ago, and I'll show you that one now. And this article was published in 2023, a few years ago. And you can see the second author there is actually Professor Madi here, who works here in Soweto with us. And it showed that they developed a bivalent prefusion F vaccine to give to mothers that was highly efficacious. And the numbers we're talking about is phenomenal. It's rolling out in Europe and America now, and the numbers are phenomenal, with the efficacy over the first 90 days against medically attended severe LRTI of 81%, and about 67, 68% up to 180 days. So the numbers are amazing, and they're doing great work there with these vaccines, and hopefully soon this will become more available. But as I said, 81% efficacy, that's extremely high number. And these vaccines are usually given, well, they're recommended to be given to the mothers between 28 and 34 weeks of pregnancy. And then it leads to that efficacy. And that's great news. And one of the first things that came out in our new battle with RSV. And hopefully soon we'll have that available. We don't have a pricing for it yet, but hopefully soon it will become available. And if a lot of pressure is put on by all of us, to the people with the money, and this should become readily available, hopefully, because it'll make a huge financial difference to the whole country. Your next step in your armory against RSV is the monoclonal antibodies, and this started off in 1996, first with RSV immunoglobulin IV, and this already showed in 1996 it was very efficacious against RSV in all groups. And it caused a 41% decrease of RSV infection in hospitalized children over all the groups. And this was an amazing thing. It was quite difficult to give and quite labor intensive to give, but this worked quite well. And what they did there is they basically took the serum of people with high RSV titers and made them into a cocktail and gave them to individuals. And it was highly efficacious then already. But not too long after that, it was followed by the development of palivizumab, which we all probably know as Synagis. And this is a humanized monoclonal antibody directed at the RSV protein F epitope site 2 that I showed you guys earlier on. And the big trial there was the IMPACT trial, which showed the IMPACT trial was a massive trial done across 139 centers in America, Canada, and United Kingdom, and it showed that palivizumab resulted in an overall decrease of about 55% in RSV hospitalization, and about a 78% reduction in RSV hospitalization in premature children with no BPD, and 39% reduction in children both with prematurity and bronchopulmonary dysplasia. So that was huge. That was huge. And it's still licensed now. It's licensed for children under 36 weeks of gestational age who will be younger than 6 months at the start of the next RSV season, or less than 2 years of age for those requiring treatment for BPD and chronic lung disease in the last 6 months, or for under 2-year-olds for children with hemodynamically significant congenital heart disease. The problem that we had though with palivizumab, and it's better now, but was the pricing. I'm not going to go into that, but the price of the drug. But if you weigh up the price of this drug compared to the price of admission, it's probably still quite a good option. I must say, with the thing with palivizumab there was that it would have to be given a month just before the RSV season started, and it would be given monthly throughout the RSV season. So you usually need about 4 to 5 doses throughout the RSV season to cover completely, expanding the price of these drugs, obviously. After palivizumab, there was a lot of headaches as well. There was motivizumab and suptavimab. Both of them did not were discontinued for different reasons. We don't have to go into those ones. And then finally, over the last 2 or 3 years, we had nirsevimab that's made the news, and it's now has FDA approval and has European approval, and is at SAPRA here in South Africa at the moment. So basically, nirsevimab is a monoclonal antibody against the epitope 0 of the pre-fusion RSV protein. And what they've done is they've actually introduced a triple amino acid in the FC region. And don't worry, don't want to bother you too much with the details, but this has increased the half-life to about, well, we can essentially give one nirsevimab injection before the RSV season, and it covers you throughout most of the RSV season. So extremely good. And we can see there as well the efficacy data, nirsevimab versus placebo, it's been great for both premature children and for late preterm and term infants as well, with the efficacy sitting for all these groups, preterm, term, and late preterm, sitting at about 75% in preventing medically attended RSV-associated LRTI, and in the 60% in preventing hospitalization from RSV-associated LRTI. So really a great drug if you can get hold of it. As I said, in South Africa at the moment, it's with SAPRA going through, and hopefully we'll have it registered soon. The dosing, I was speaking to the Sanofi people today because they're the producers of it. The pricing hasn't quite been decided yet, but hopefully it'll be much more affordable than the other drugs have been in the past. So what we need now is why are we focusing on nirsevimab and vaccines? Well, we know there isn't treatment that we have available for RSV yet, so that's a problem. We also know that we probably have to adapt the way that we implement our protective strategy or preventative strategies for RSV. A lot of the children that are at highest risk of severe RSV disease are those ones who will be born prematurely. So those ones born before 30 weeks or 28 weeks of gestational age, before the maternal vaccination has been given, or before there has been enough time for the RSV vaccine to protect them. And for these children, we probably would need the long-acting monoclonal antibodies to help us through that time period, or for the ones that haven't received the vaccine. So there probably needs to be a two-pronged attack for RSV. We would give a maternal vaccination for all children, that should cover all children from about 30 weeks onwards and should cover them to at least 5 to 6 months after birth. And then for the ones who didn't get the vaccine or who didn't get the vaccine, you need at least a week to 10 days for the vaccine to have some kind of efficacy, but are born during that period and close to the RSV season, we'd probably need to give them nirsevimab to cover them through their first RSV season as well. And hopefully in the near future, hopefully we'd be able to get a RSV vaccine that can be given to children as well in the first few months of life, which would cover them as well then for later RSV infections and at a later age. So my take-home message today would be, it's the second leading cause of RSV is the second leading cause of global childhood mortality, but it has a substantial larger group of morbidity. So it's not just the mortality, it's the morbidity that's a huge problem as well. And we don't have the exact numbers, but 99% of all RSV-associated deaths occur in low and middle-income countries and mostly out of hospital. So we're probably underestimating the severity of RSV. Children with severe RSV, the majority of them is going to be under 6 months of age with bronchopulmonary dysplasia or other underlying diseases. And those are the children we need to protect the most and we need to protect first. And for us to be able to get the vaccines in our EPI and to get nirsevimab for the children who fall outside the vaccine window, there's going to have to be a lot of raising of awareness and a lot of loud voices will have to be heard before this gets accepted into our EPI, but we're going to have to do that to promote the vaccine acceptance and the implementation of the vaccines. So as a final slide, on a happy note, I'm elderly, so I grew up with the first Star Wars, and the first Star Wars was great. And then we had a huge dip for the second trilogy of the Star Wars. But there's always, if you look at the third one, there's always a new hope, and that's how we feel now. It's like the Star Wars movies. They took a hell of a dip, but now there's a new hope coming, and hopefully we'll have something that can really protect us or protect the children against RSV, and relatively soon as well. And with that, I'm going to end my slideshow. Thank you very much.
Thank you very much, Professor Verwey. I think this was quite a great lecture, actually, for those involved with children, but also all those who had qualified and they may not be in the pediatric space, but all of us have got children in our homes, in our relatives, and everywhere. And we know that this is one of the most common conditions that afflict children, especially in the winter that we are going to. I think this was a great lecture, and also a revision for those who have not visited this topic before. I must say to those who are in the audience who may want to follow up with Prof. Prof has written quite a lot on this topic, and he has published in reputable journals on this. A lot of them as the main author, and I think he can be contacted even after this. I should have said at the beginning that people can ask questions. You can type your questions in the chat, or you can raise your electronic hand, and I'll recognize it from my side, and we will take the questions. Some of you have already posted 1 or 2 questions in the chat group. We'll go through them now, and Prof. Charl will respond to them. Some people use Teams and not Zoom, and our clinics webinars are on the Zoom platform, and I think the controls are slightly different, and people have said that they have a problem raising a hand with Zoom. If you go to the tabs at the bottom, the one that said react, if you click on react, then there will be quite a number of reactions there, and then there's one that said raise hand, and you can just click on it, and we will be able to see your hand as you do that. But Prof, there's a question from, I think, let me go to the first one that I saw in the chat. I think it's from Dr. Mortar Belgith. He says, how do we diagnose bronchiolitis, the actual diagnosis? I know you touched on all this, but I think people want just a little more detail. How do you differentiate?
I'm very happy I didn't have to try to pronounce that name, to be honest, because I was looking at it as well, and I have no idea how to pronounce that surname, but thanks for the question. If bronchiolitis is a disease of the first 2 years of life, so if you have a child who comes in with, basically the hallmark will be tachypnea, so fast breathing, and difficulty breathing, so they can have intercostal recessions and mostly subcostal recessions. If you have experience with children, you'll also see that their chest is actually enlarged. They've got an increased AP diameter, increased chest size, and that's because there's too much air in there, okay? So that's basically the hallmark. So when you listen on the chest, you're going to hear fine crackles throughout, and occasionally some wheezes as well, but mostly a child with respiratory distress and hyperinflation with crackles or wheezes. That's how we diagnose it. And I don't know where all the audience comes from, but I'm from Joburg, and in Joburg there's a typical RSV season, which starts at about the beginning of March and goes on to about June. So if you have a child who comes in with respiratory distress, with features of hyperinflation and crackles on the chest during this time of the year, or a few weeks' time, that's bronchiolitis. We generally don't even do an X-ray on these children. We don't take bloods on the children, because it's such a typical picture of hyperinflation and respiratory distress. That's how we diagnose bronchiolitis.
Okay, I see some people typing in the HPCSA registration numbers and so on. Maybe it's not really necessary. I think all of you, when you registered online, I think one of the details we needed from yourselves was your HPCSA registration number. I think we used that to inform HPCSA that you did attend this webinar, and as a result, they accredit you with automatically with the HPCSA CPD points. You do get an email from HPCSA directly, so we don't confirm. Initially, we used to confirm and send you emails back from clinics, but we feel that the emails that you receive from HPCSA and confirming, usually after about a week to 2 weeks, you get an email and saying that your CPD profile with the HPCSA has been updated, and you can check that you did receive. So that is fine. But I think Dr. Belbis asks another question. Until which age can RSVP be diagnosed, I suppose?
Yeah. Well, generally we keep getting RSV every year. Our body doesn't really get immunity to it, so we keep getting RSV every year. But as I mentioned in the beginning, the hallmark of disease is it's the disease of the small airways. So as we grow up, our airways grow bigger and we have less symptoms. So generally, as adults, we'll get RSV every year, but it'll present as a cold, a small upper respiratory tract infection. But it's the first 2 years of life that has the typical picture of that where it causes a bronchiolitis and causes the respiratory distress. So after that, they'll likely get RSV every year or every second year again, but it'll become less and less severe as they grow bigger in size.
Okay. There's a question, I think, from Dr. Linda Klein-Bailey. What is the role of sugar and powder milk in aggravating circumstances in 5-year-olds?
No, there's no role that I know. I'm going to stick to bronchiolitis here. There's no role that I know of sugar and powder milk in aggravating circumstances in those children. If we're talking about powder milk, breastfeeding is the best, but that's, 5-year-olds is a different age group. So breastfeeding would always be protective and help you against RSV. But there's no known role of sugar or powder milk in aggravating RSV infection per se that I know about.
Yeah, quite a number of people in the audience, Prof. And I think, let me tell you, I think at one stage I counted 463 participants in the webinar tonight, which is one of our big numbers. Yes. So quite a number of them have posted in the chat saying very excellent talk, Prof, and excellent presentation. But here's a question. Yeah, what's the outpatient management of RSV? And does physio play a role?
So the outpatient management of RSV, generally we admit children to hospital when they're in moderate or severe respiratory distress or they're hypoxic. Before that, they can be dealt with at home. And basically the treatment then would be keep them comfortable, keep them happy, make sure you keep their nutrition up, make sure you keep their hydration up, make sure you keep their temperature down. There's no role for cough syrups or cough medicine or any nebulizations to try to open up the lungs, because it's not that. The pathophysiology is different. So basically to try to keep the child comfortable and to give supportive, comfortable, comforting treatment to the child would be my answer to that. But there's nothing that you can buy at the pharmacy that's going to make them, make the chest problems better. That's just time is usually the answer there, or oxygen if they require it, but then it's not outpatient. So keep the temperature down, there's been a talk about honey and the tryptophan in honey to soothe the throat. That could, but I wouldn't go chasing cough syrups or anything like that. Physio does definitely not play a role initially in RSV, because RSV, as I said, it's a small airway disease. Later on, if you get more severe disease and you have collapses, or if you have atelectasis, then maybe we can start talking about physio. But initially, physio does not have a role in your standard bronchiolitis patient. It's a different pathophysiology that where physio is not going to help for that one. I can take the next question. Said, would pulse oximetry be a useful, accurate tool in the rooms? Definitely. Here at altitude, we generally admit patients with saturations less than 90%, where at the coast it's usually 92%. So it would help to know when you're starting to require oxygen on these babies. You can generally look by the respiratory distress that they have, but you can also use pulse oximetry in the rooms to help for that as well. And if it's veering towards the lower side, it's much safer to at least admit them for observation in case they were still going to deteriorate for that one.
Yeah, that question was asked by Dr. Jeffrey Melman. There is another question. Should we, I think I've mentioned that one. Oh, should we do respiratory panel in all bronchiolitis?
Yes.
That question is asked by, I think, Dr. Sibuti Tsotetsi.
Yes, no, the answer there is no. If once again you're up at the Highveld between end of February and June, if you have a child who presents with a typical bronchiolitis, it's 80 to 90% going to be RSV. We like doing respiratory panels because, and a bit, when we start talking about June and July, then where influenza comes in, then it might be helpful. But for RSV, remember, there is no treatment for RSV. So it's not that your respiratory viral panel is actually going to make a difference to your treatment. So where I work, we actually get respiratory panels on everybody because it's done for research purposes and it can be helpful for isolation purposes. So we know this child's being admitted with RSV. We need to put them with other children with RSV or an isolation cubicle. And from that point of view, respiratory panels might be helpful for infection control. But for your day-to-day management of your typical bronchiolitis, we can't treat these viruses. You're going to treat them supportively, so then it's not necessary.
Yeah, Dr. Ashraf Ali Mohammed asks, in our socioeconomic environment, how will a mild to moderate RSV be treated at home? Because realistically, most patients cannot get access to oxygen at home.
Yes, so basically, I always say there's four reasons for admitting patients to hospital with RSV. One of them is moderate to severe respiratory distress. So if they have increased work of breathing and they're working hard, children get tired quite quickly. They become exhausted quickly. So then I'd rather admit them. The second one is if they're hypoxic, I would admit them to hospital. I agree. Maybe in some of the private centers, we can quickly get home oxygen on board. That's not realistic for where I work, at least, or where the majority of people in South Africa work. So if a child needs oxygen, so if the saturations drop below 90%, I would definitely admit the child to hospital and not keep the child at home. The other reasons we admit patients is when they can't maintain their own hydration or nutrition, even with full parental support, then they need to be admitted as well. And the last one is if they don't have socioeconomic means to bring themselves to the hospital if we ask them to return. So if we say your child looks fine now, but if he gets worse, please bring him to hospital. If that's not economically viable, then we'll admit them straight for observations as well. So I think the answer there is if they need oxygen, they need to be in hospital. If they need nutritional support and hydration support, they need to be in hospital. Otherwise, keep them comfortable at home with your Panado, your paracetamol or Nurofen, and just keep them comfortable, but otherwise they need to be admitted.
Yeah, Dr. Mohammed Chaya asks, does cystic fibrosis predispose or confound RSV outcomes?
Interesting question. And cystic fibrosis patients are more prone to more severe lung disease. So when they do get infections, they do get worse infections, or it can lead to what we call an exacerbation in cystic fibrosis, where they have increased coughing, increase in production of mucus. So they might need extra treatment for that. So cystic fibrosis doesn't predispose you to RSV, but it can predispose you to getting a more severe infection at an age where you wouldn't expect children to actually become very symptomatic from RSV. So it could be a problem there as well.
Yeah, yeah. Just a question from another question, Prof. Just to go back to the vaccination. Is vaccination given routinely, like the measles one, or is it by choice from mothers and fathers, of course?
The measles vaccine.
No. You remember we talked about vaccination for
Yes,
RSV.
yeah.
Is it freely available? Is it freely available? Is it given routinely, like the measles vaccine is given at a certain age of the baby?
Yeah. At this moment in time, the RSV vaccine is not available in South Africa. Whether it's the maternal vaccine or the vaccine for elderly patients is not available in South Africa. Overseas, it depends on where you are. Each country has their own approach. Interesting enough, speaking to colleagues in Spain and Italy, where in Spain they almost have global coverage of nirsevimab in premature children. They don't have a RSV season anymore. They're not admitting patients during the RSV season anymore because they've almost managed to stop the RSV epidemic that happens every year. So these medications are extremely efficient if you have the financial means to supply them. Unfortunately, we don't have them yet. We don't have pricing for them yet either. So the first step would be to get through SAPRA, and when that gets confirmed, then we'll start only hearing about the pricing options for these medications and for the vaccines. And hopefully then, if we do get the vaccine through, the vaccine does have clearance, but we don't have it yet. If we do get that through, hopefully we will get that onto the maternal vaccination schedule.
Yeah, you did say that antibiotics are not part of the routine treatment because this is a viral infection. But you mentioned that in severe cases, hospitalized children, there might be consideration for antibiotics as prophylaxis, and if so, which antibiotic would you use?
Yeah, so there is some evidence that up to 10 to 12% of children with severe RSV infection could have bacterial co-infection, so they might need antibiotics. Your standard patient that comes in, your standard child who comes into hospital with respiratory stress and hypoxia and precisely to nasal prong oxygen does not need antibiotics most of the time. But if you have a child who's rapidly deteriorating and requires high flow nasal prong oxygen or nasal cannula oxygen or invasive ventilation, your chances are bigger that these children actually have a bacterial co-infection as well. And those ones I would cover with antibiotics. Generally, I would follow the normal, if you have data from your own hospital, what your most likely pathogens are. If you don't, I would follow South African recommendations for the management of pneumonia, which would be just your normal augmentin. If they can, amoxicillin co-amoxiclav. Let's keep it at that one. If they generally, these children are quite sick severely, so they won't be able to tolerate orally, because oral antibiotics are just as good as IV if children can tolerate orally. But in these children who are quite sick and who require quite high volumes of oxygen, I would give it IV then and take it from there.
Prof, thank you very much for a talk. I didn't see any more questions and I didn't see any hands today, but maybe just for the future, participants are allowed to ask questions at the end, and they can even unmute and speak during question time. And whether it's a question or a comment, you're welcome to do so if you want to interact. I see there's a hand from, I think it's Dr. Sheikh. Let me see if you can unmute Dr. Sheikh. Everywhere, or Sam, can you unmute Dr. Sheikh? And there was a hand, I think it's disappeared. Okay.
I think it disappeared, yeah.
maybe he was testing the system. He was testing his system, but thank you very much. I think I'm not alone here with our team in the background everywhere. Thank you very much, Verwey Matetuka, Sam Mutupeng, and Palakele Nkosi, who help us with the gadgets in the background. But I'm going to hand over to Professor Sipati Makunyani, who's one of the professors we rely on in our group in clinics. Clinics is a group that owns 8 hospitals within South Africa, 8 private hospitals, 5 of them acute care hospitals. And we've got quite a quality assurance team of 7 professors who are academicians in our medical schools who assist us with quality maintenance of clinical governance. And we've got one of them today who is head of ophthalmology in University of Pretoria, Steve Biko Academic Hospital, Professor Sipati Makunyani, just to do a vote of thanks for Professor Verwey. Professor Makunyani, you can go ahead, please.
Thank you very much, Dr. Kinoshi. Yeah, as we conclude this very enlightening session, I would like to express our sincere gratitude to Professor Verwey for these invaluable insights into RSV. I am an ophthalmologist, but I did notice and I heard that you highlighted the fragility of our lungs and the impact of viral infections, particularly this RSV, which remains the most common cause of a lower respiratory tract infection in infants. We have been reminded that supportive treatment is the mainstay of management, ensuring that we provide optimal care without unnecessary interventions such as antibiotics. Additionally, ongoing research into vaccines and monoclonal antibodies seem to be offering hope for future preventative strategies. And thank you so much, everyone, for having joined us in this webinar. Your participation and engagement has been wonderful. And let us take these critical insights forward as we continue striving for better respiratory health outcomes for our little ones. Thank you very much. Stay safe. Over to you, Dr. Kinoshi.
Thank you very much, Prof. We will be sending out invitations for next week, Thursday's webinar. We will not have a webinar on the days just before a holiday, like the 20th, I think it's the 20th of March is a Thursday. We won't have a webinar, so we'll let you know, but we will be sending out on your emails that we have for a webinar for next week. We've got speakers lined up for the next 4 to 5 weeks. But again, just a reminder that if any of you would like to do a presentation, please do contact us anytime. Or if you would like to recommend someone to do any presentation, you are welcome. Good evening, and thanks for having logged in.
Thank you very much, everybody. Thanks for inviting me. Have a great evening.
Thanks, Prof. Thank you. We'll talk.